So patient blood management is not really everyday language in medical terminology. It's a relatively new term that it's important to understand where we're coming from when we talk about it. We're really not just talking about transfusion management. We're talking about the whole blood health of the patient and keeping the patient's blood and blood cells healthy so that they don't require a transfusion of any particular blood component. So for the next 40 minutes or so, we'll talk about the following items. We'll review the definition of patient blood management. We'll talk about what the benefits are, the risks of transfusion, and why we seek to reduce transfusions in our patients. Patient blood management initiatives that we're undertaking here at North Shore Hospital and some of the successes and some of the challenges that we've experienced. And then we'll end with a couple of case studies just to give you an example of the ways in which nurses really come in contact with patient blood management dilemmas and how the nurse may be actually the first person to be able to recognize that patient blood management can be exercised in a number of different scenarios. So this is what we call the four-leaf clover, and it is a four-leaf clover of the four tenets of patient blood management. And in the order in which we usually talk about them, they start with the upper right-hand corner, managing anemia. So if the patients are not allowed to remain anemic, or if they're found to be anemic and treated properly, then there's much less risk of transfusing red blood cells when you're starting with a higher hemoglobin. The second tenet is optimizing coagulation, and that involves minimizing bleeding and preventing patients from bleeding to the point where they would require a transfusion. The upper left tenet is interdisciplinary blood conservation modalities. And this is truly an interdisciplinary endeavor. And when you see the makeup of our task force, you'll appreciate the multidisciplinary nature. And then finally, it's a patient-centered event. And that's what we're all for, is patient autonomy, patient decision-making, and a patient-centered initiative. When you talk about transfusions, you're really talking about a product-centered or a blood-centered initiative. But patient blood management is really centered on the patient's needs, the patient's blood health. So there's the definition you see before you. It's a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. And that's a WHO, a World Health Organization definition that was just published last year by a multinational group of experts.
Dr. Shaw, I'm
yes.
sorry. Is it possible for you to open up your slide a little bit larger than it is?
How do I do that? It might be because I'm on presenter mode. I don't know if that's why.
Yeah, Doctor, if you go ahead and hit the Use slideshow up in the upper left-hand corner, that might.
That one.
There you go.
There
we go.
Thank you.
Oh, thank you. Okay. So did you see the presenter mode then?
Yeah, we did.
Yeah, okay. Great. So how do we do this? We enhance the patient experience. We get the community involved. This does have a subset of appeal to the bloodless community, the Jehovah's Witness community, those for whom blood is not an option. And we also focus on patient outcomes rather than the actual transfusion itself.
All right. So I'll take over for a little bit, and then I'll hand back to Dr. Chorlessis in a little bit. So, before I talk about what's on the slide, I did want to just reemphasize what Dr. Chorlessis was saying, which is that, sometimes this is looked at as a way of saving money or saving the blood supply. Yeah, I would say that some of those are sort of byproducts of this, but really the focus here is the patient and what's best for the patient. And I think it's important to keep that in mind. And, if we focus on that and view that as the primary reason to pursue patient blood management, I think we sort of are able to make much better inroads because I think everyone in the room, as well as everyone that's listening, wants to do the best thing for their patient. And I think, sometimes there's a misconception by giving more blood to the patient is sort of better for them. And we're finding out more and more as we study this and review the literature published around the subject that yes, blood can save lives and is needed for some patients, but uh, if it's transfused when it's not necessary, it does much more harm than good. So with that, basically there's studies that have looked at this in depth and have found that unfortunately a lot of transfusions are not necessary or appropriate. Uh, up to 59% of transfusions that were studied in a large cohort of patients were found to be inappropriate. There's some uncertainty in some of the transfusions, and out of this large cohort, only 12% were actually found to be appropriate. Obviously, this does depend on the institution. It depends on the patients that are being studied, but obviously these are startling numbers where we definitely know maybe at our hospital these numbers aren't quite reflective of our practice, but I'm sure there's room for us to improve. And clearly, this is something that is a big, potential, something that needs to be worked on throughout the country as well. Um, in addition to that, up to 68% of mortality was tied in some studies to transfusion. The length of stay was increased by 16 to 33%. And there's other complications that sometimes, just because a patient does not have a reaction when you're transfusing them, we know that when we study this in a large number of patients, some of the side effects that are not as obvious, and we'll talk a little bit more about that later, contribute to some of these other statistics that are on the slide, including sort of an increase in readmissions, reoperations, complications of the patient being in the hospital. Sometimes it's not obvious, but maybe related to the patient being transfused. Increased rate of infection is been proven to be seen in patients that are transfused, and obviously costs. Anytime you're giving blood, not only is there cost of purchasing the blood and providing it, but there's actually a fair amount of cost that includes taking nursing time to transfuse the blood, and sometimes that's a cost that's overlooked. And that is a significant contributing factor to the cost of blood transfusions. Next slide, please. Thank you. So as many of you know, when a patient's being transfused, one of the big concerns that the patient has is, they've heard about this, they might have seen things on TV. They're concerned that, hey, I'm getting blood. I'm concerned, what else might I be getting? Could I be getting an infection? Like, especially in some patients, they're concerned about infectious diseases like HIV and hepatitis. But in addition to that, there's actually a lot more that we really should be aware of and be thinking about. So next slide. So, us as practitioners, we're concerned about not just, the viruses that we might be transmitting, but uh, there's other effects that may be occurring in these patients. Transfusion reactions is obviously something we're well aware of, and why these patients are monitored so closely. And in addition to some of the infections that people are aware of, there's actually a lot of other things that a patient may get that patients often are less aware of, such as a bacterially contaminated unit, if it's transfused, can be much worse than someone getting HIV through a transfusion, as well as some of the other effects that we'll talk about that are attributable to blood transfusions. So, next slide. So one of the things that we're aware of, like I said, viruses, I think everyone knows, because of what happened a few decades ago, everyone's aware that one of the risks of transfusion is, viral transmission, including HIV and hepatitis. Fortunately, we've done a good job of testing and screening donors, so some of that has improved. But what many people do not know, there's still a pretty significant risk of bacterial contamination. And, if someone gets HIV or hepatitis through a transfusion, they may live for decades, or maybe even their normal lifespan. But if there's a bacterially contaminated unit, that patient may become very sick and may end up in the ICU and may not survive even the next 24 hours. In addition to that, we also know that there's parasites that are transmitted through blood, and there's more and more new infections that have come out that have affected the blood supply. Some that have affected in the last couple of decades that didn't really exist before were not concerns. They include West Nile virus, Zika virus. Um, Honestly, even when there was an Ebola breakout and we had some cases in the US, including cases in New York, there was a concern, how is that going to affect the blood supply? In addition to that, there's other parasites such as Babesia, um, and Chagas disease that are actually significant concerns. And these aren't risks that are theoretical and less than 1 in a million. These risks are actually more prevalent than people recognize they are. So next slide. So these are some of the numbers, and like I said, we've done a good job with HIV, hepatitis B and C, HTLV, and West Nile. But some of the other, infections actually carry much higher risk, such as bacteria. Like I said, in platelets, it's less than 1 in 100,000, which is 10 to 20-fold the risk of HIV or hepatitis. Babesia, um, there's been testing that's recently implemented and within the last decade, and the risk of Babesia has gone down, but it's still something that we see through transfusion, not uncommonly. Honestly, I've seen cases at North Shore and LIJ just prior to this Babesia testing being implemented that were transmitted because of blood that we transfused in the hospital. T. krusei, which is basically Chagas disease. Fortunately, we're testing for now as well, but that's something that was also seen more commonly prior to this testing being implemented. Um, CJD, basically, it's a variant mad cow disease. These are prion diseases. Um, there is a risk that that could be transmitted through transfusion as well. And many patients are not aware of some of these things that could be transmitted through transfusion. And it's not just HIV or hepatitis, but us as practitioners should be aware. And knowing these risks is a part of what we should be using to help make the decision of whether the patient needs blood or not. Next slide. So the other thing that's happened, the blood supply has become safer with some of the testing that we've added, but each test comes with a cost. So as you can see, HIV, hepatitis B, hepatitis C, the risks have gone down and now are basically less than 1 in 1 million. But the cost of that is significant, and that's part of the reason why the blood costs as much as it does today, because all these tests have to be performed. It's not so much collecting the blood and having the donors come in, but it's every unit of blood that's transfused has to be tested for these, and that obviously contributes to the cost. But it has helped with safety. But keep in mind, there's new um, infections that come about. Obviously COVID is another one. Fortunately, that was not able to be transmitted through blood transfusion, but we don't know if the next infection that we encounter will be or not, and we would have to come up with testing or strategy to protect the patients. But ideally, if we can avoid the transfusion, if the patient doesn't truly need it, that's the best. Next slide.
So I think, is this one of my slides, Dr. Chibber?
Yeah, I think we're about to hand off here
Oh,
right
there
after
you
this
go.
one.
You've got one
Yeah,
more. Okay.
yeah, right after this one. I think I have one more after this, and then we're gonna hand off. So we're aware of some of the infections. There's others that we may not be aware of. Certainly, the patients may not be aware of. But in addition to that, there's other complications of transfusions that include transfusion reactions. Um, some of them are pretty severe, like a hemolytic transfusion reaction can be life-threatening, but they're not as common. But febrile and allergic reactions, I think many of you have probably seen these in patients when you've transfused blood within the hospital yourselves. These are not uncommon, probably 2 to 3% of transfusions you will see febrile or allergic reactions. And keep in mind that, if we've seen some of these, we might realize that, okay, this is not something that severe. But if you're the patient, you are not, anticipating having a transfusion reaction. You may not know much about it. So it can be quite disturbing for patients that are having these reactions, even if it's just a fever and nothing else. But keep in mind, there's a risk that the patients can have more severe reactions, including severe allergic, anaphylactic. There's TRALI, which is basically acute lung injury that can be induced by a blood transfusion. And these are, reactions. TRALI reactions can have patients end up in the ICU on ventilators, and there's cases of mortality reported with TRALI every year. Um, Basically, what's happening is that the patient's white cells are being activated within the lungs, damaging the lungs, and the patients develop ARDS. We also realized that in addition to trolley, another common reaction that is often underdiagnosed or is not looked at as something related to transfusion, but it actually is a pretty significant problem related to blood transfusion, is something called TACO, or basically transfusion-associated circulatory overload. Sometimes we just think of this as congestive heart failure, but transfusions can certainly cause these reactions, and they can be quite severe because unlike IV fluids, when you're giving blood, the blood is going to stay within the circulation, and the patient's heart has to pump harder to be able to keep that blood flowing. And that's why they're at risk of these circulatory overload, especially with red cell transfusions, if done rapidly or in patients that are predisposed to it. Hypotensive reactions, we actually see these as well. Patients can drop their blood pressure when they're transfused. And in addition to that, you can have hemolysis that's not immune. It could be mechanical. It could be, if a patient's transfused through a line where there's other medications or fluids going in that are not isotonic, you can have non-immune hemolysis as well. Next slide. Yeah, I think actually I think I have one more after this. So transfusion reactions, like I said, 1 to 3% for febrile and allergic. Fortunately, some of the other ones are less common. 1 in 5,000 for trolley, which is, unfortunately not as uncommon as you think. Keep in mind, we transfuse about 25 to 35,000 blood products in this hospital every year. So, there's probably half a dozen patients that potentially could have trolley in this hospital. Taco, again, uh, not uncommon, probably depending on the study, about 1% of patients that are transfused may develop a circulatory overload, which may end up getting them admitted to the ICU. ABO incompatibility obviously is something very severe, which is why we, are very careful when we're drawing blood. We have everyone that draws blood sign the tube to make sure we can find out what happened in case there is misdraw. And we actually have mechanisms in the blood bank where we double test before we give anything other than Group O blood. Um, and unfortunately, very rarely there can be fatal reactions related to incompatibility. Uh, but sometimes these patients will develop antibodies. So it's not incompatible when we gave it, but they'll make antibodies and start to break down the blood. So that's a delayed hemolytic reaction. They're not that uncommon, 1 in 2,500. So, these things do occur in several patients within this hospital every year, but fortunately, they're usually not as severe, but still Delayed reactions can affect the patient's kidneys and some of the other functions, and they'll drop their hemoglobin again, and we'll have to work them up and figure out what sort of blood they need. Next slide. Yep, and I think this is my last slide before I hand off to Dr. Sherleston. So these are the rates of fatalities, numbers and rates, percentage of fatalities that are reported to the FDA. Anytime someone has a severe reaction, we have to report it to New York State, and all fatalities related to transfusion are reported to the FDA in addition to New York State. And basically, the most common now is actually circulatory overload, because it's pretty common. So many patients that have TACO or transfusion-associated circulatory overload will not succumb to the reaction, but because it's so common, there are, it looks like between 2015 and 2019, there's 65 patients that actually were reported to, and this is something that's probably underreported. In addition to that, some of the other top ones are trolley, which we've talked about already, and then severe allergic or anaphylactic reactions, as well as ABO and non-ABO hemolytic transfusion reactions related to incompatibilities. So with that, I'll hand off to Dr. Shore-Lessison for the next few slides.
All right, thank you. Thank you, Dr. Chibber. So now that you've heard all of these horrible things that can happen when you have an adverse reaction to a blood transfusion, you might be thinking, well, what if you get away without any of those adverse events? Then it's not so bad to receive a blood transfusion, right? If you can get away without a hemolytic reaction or an allergic reaction. But actually, it's these subtle white blood cell effects that are really unable to be seen, but they are taking place, and they are responsible for immune modulation. And that's what really is responsible for the adverse outcomes that are long-term that we see in patients after they receive a blood transfusion. So some of the things you can see here, we've already talked about. Dr. Chibber's already talked about infectious complications and acute lung injury, which we would call trolley. But the immune modulation means it's rendering the patient's immune system less competent. And that can result in a cancer occurrence or recurrence, which has been documented. And any sort of immune modulation is really a risk for a patient who's either susceptible to a cancer or has had a cancer and may be susceptible to a recurrence. And also infection. You might have heard that patients who have gotten transfused are more susceptible to infection, especially perioperative infection. And that is the case. And that is a result of the white blood cell effects in the blood transfusion that the patient is experiencing. So let's just look at a study or two that demonstrate this. These are studies from a number of decades ago, but they still hold true. And there still are larger demographic epidemiologic studies showing that cancer recurrence remains an issue, especially as a result of red blood cell transfusion. So in this colorectal surgery population, they compared autologous pre-deposit transfusion. They followed patients for 22 months, and they compared the autologous to an allogeneic blood transfusion. They tried to eliminate the confounding factors. And what they basically demonstrate is that there was a lower survival rate, 69% versus 81% in patients who were transfused. So the lower survival rate pretty much attributed to cancer recurrence in this 3-year period. But also, as we just discussed, the infection rate was also higher in the transfused patients, 39% versus 24% with a postoperative infection. So these are actually 2 studies by the same group demonstrating the adverse tumorogenic or oncologic effects of blood transfusion. Looking at postoperative infection, similarly, colorectal surgery patients, a similar comparison of Buffy coat poor blood versus leukodepleted blood when transfusion was indicated in these patients. And they compared then the Buffy coat poor blood to the non-transfused. So seemingly the Buffy coat poor getting rid of the white cell components, seemingly a safer product versus the non-transfused patients. And still, even with what was considered a safer product, when you compare the Buffy coat poor transfused patient to the non-transfused patients, you can see that the wound infection rate is much higher, abscess rate is higher, and pneumonia. So all these different sorts of commonly seen infections that occur in surgery were higher in patients who received a blood transfusion. And another comparison of patients looking at wound infection, abscess, pneumonia. This, I think, is the same study that we just looked at. So we really want to avoid transfusing patients. We can see that there are overt complications and there are subtle, longer term immune modulated complications. And that's why we feel that patient blood management, which starts at the heart of making the patient optimally prepared for either a medical intervention or a surgical intervention, is really where we start. And so it's about reducing the demand, right? When we, and this is what we've recently discussed too with the blood shortages. Dr. Chibber probably knows way better than I do that there have been extreme blood shortages in New York State, in the country, presumably due to COVID and the reduction in donations that's occurred since then. But if we look at blood supply as a supply issue, then we are going to feel like we have a reduced blood supply and we need to get an increased donor pool. But if we look at it as reducing the demand and we increase patients' hemoglobin and we decrease their bleeding, that's where we end up practicing what is our definition of patient blood management. So take a look at the multidisciplines on our task force. We have clinical disciplines, anesthesiology, cardiac surgery, critical care, trauma, transplantation, hematology, nursing education. And then we have non-clinical representatives in quality, IT, and administration, and that is senior level administration as well. And the goals of our task force are to keep it patient-centered, to minimize exposures to blood products, avoid transfusions, and then also to embrace the bloodless community. And in doing this, we also end up, as a side effect, reducing waste. And that's a pretty good side effect. So in other words, a lot of blood products are ordered and sometimes they're never transfused. And by the time they could end up being returned, even if they could be returned, they might be expired, they might be at the wrong temperature. So by not ordering the blood products and not thinking that a transfusion would be necessary, we really end up reducing a lot of wasted blood products and cost. But we tend to look at the patient benefits. So we try not to focus too much on cost in our PBM task force.
So I'll take the baton for a couple of slides here. Yeah, and what Dr. Schorleson said is very true. So the costs are significant, even though we want to do the best thing for the patient, and that's why we're talking to you today. But just purchasing blood, that's not the cost to transfuse the blood, but just purchasing the blood from New York Blood Center for this health system it comes at a cost of over $100 million a year. Um, so, the health system is quite large. We have a lot of hospitals, but, it is substantial. And then if you take into account that, we have to have blood banks to hold the blood and to do the testing, and then we need nursing to transfuse these units, the cost is actually a lot more than $100 million. So it's something that, if we're able to save, even 5% of transfusions, we're talking about a large number. But we want to do that, obviously, to save to save in terms of the cost is great, but really we want to do this because it's the right thing for the patient, and the cost saving is really sort of a side benefit, and I think that's how we should look at it, as Dr. Schorleson said. And the it also helps us be stewards of the blood supply. You know, blood shortages are way more common than we'd like them to be, and they've been worse since COVID. I think the overall donations are down since COVID. And another phenomenon we kind of saw that was really challenging, probably it's actually for sure I can tell you it's the worst blood shortage we had was in 2021 throughout the whole country coming out of COVID when people started to come back to hospitals and get healthcare, get the surgeries and have their cancer and other things treated that may have been put off. The demand for the use of blood went up astronomically, and the donors were not donating. And at that time, we really had a very severe shortage of blood throughout the country, especially in New York. And, being stewards of the blood supply uh, basically can minimize these effects and certainly will help in the periodic blood shortages we see all the time. Basically, especially around the holidays, there's less donors donating blood, so we see that. So we don't want to be giving patients products that they don't need and then not have enough for the people that really need it. So that's another important thing to kind of keep in mind. These are all reasons to basically transfuse only when necessary and avoid it when possible. So as Dr. Schwarzenson said, we have a pretty multidisciplinary task force with a lot of different departments involved. Um, and in addition, and some of the initiatives that our team is responsible for is one of the things is what we're doing now. We're sort of providing information and education to whoever we can get to listen and learn about patient blood management. And we want you to be aware of this. There's a lot of information available online. We'll share some links with you as well. But the education is really important because I think if we have enough people know about this and the fact that we're better serving our patients by being aware of this and being stewards of the blood supply and transfusions, we're really improving the health of the patients, and education is a big part of it. Um, some of the other things that we've done to aid in this is we've revised the indications for transfusions that are accepted in this hospital, and that's also been reflected in the computer order entry. So this is something that I have to say was a project with a lot of effort put in by Dr. Shore Lesterton and my predecessor, who sort of worked with the IT team to help amend the order sets to promote these practices. So when someone is trying to place an order for blood, we actually made it as helpful to them as possible in terms of guiding them to make sure they're ordering blood only when it's appropriate, with certain criteria and information in the order set itself, as well as sort of having the electronics of the blood order set be something that aids in appropriate ordering. So if someone is not bleeding, generally, we don't want these patients to have multiple units ordered at the same time. And the CPOE, computer provider order entry, is something that enhances that and will help do that. In addition to that, we use the electronic medical record to help audit transfusions to make sure that they are appropriate. And if they're not, we sort of want to reach out to find out, hey, why was this patient transfused, and maybe educate the provider in terms of, better practice going forward. Next slide.
I think this is animated to show the.
Okay, I'm
Hmm.
not seeing the animation, but it might be my computer.
Oh, there
Oh,
we
there we
go. Okay.
Yeah. So, and
Okay.
honestly, it's something that was done really well here. And now that we're looking at Epic and we're putting in order sets into Epic, uh, we're sort of teaching the Epic team that there's actually a better way to place blood orders than what they usually do. And it's something that they may actually take to other institutions from here as well. It's something that really I think we should be proud of. Um, so, in addition to that, we make sure that patients aren't transfused unnecessarily by reviewing the MSBOS, or the maximum surgical blood order schedule. This is basically a guideline in terms of which surgeries or invasive procedures should have blood ordered, or even a type and screen. Why order type and screen on everybody if they don't need it? And as we sort of transition, you'll also learn that one of the ways we could do a better job to not transfuse as much is to prevent anemia. And one way to do that is to not sort of phlebotomize patients if not necessary. So why draw these type in screens and cross-match blood unnecessarily? And I think Dr. Shore-Lesson is going to talk a little bit more about that in the next few slides.
Great. So here's the rest of our education and coagulation management initiatives from the PBM task force. And these, I guess we could group together and call them blood conservation. Education is always number 1, 2, and 3. Education has to be ongoing. We would love to meet with you every year. We'd love to meet with all the different disciplines in the hospital that are ordering blood products every year. We'd love to meet with the trainees, the medical students, the nursing students, and really get patient blood management on everybody's radar from the start of practice. So that's definitely high on our list. And if you can think of other, and posting this to the YouTube channel is a great idea and really gets it out there. So if you have any other ideas for education where we can reach a large number of people that are relevant clinicians in this space, we're all ears for that. So other initiatives that we undertake are the anemia management program. This is briefly, we had mentioned that we want to identify patients earlier who are anemic, who either are anemic just because they are and maybe don't even need a procedure, but those that are coming for a procedure, for example, a surgery, and they're going to lose some blood. Presumably, if they start from a higher hemoglobin and they lose a little blood, they might not bleed down to a hemoglobin that requires transfusion. But if you present with a hemoglobin of 10 and you bleed during surgery, there's probably a good chance you're going to bleed down to a hemoglobin where your physician and the team feels that you need a transfusion. So anemia management is critical. We work with hematology, we work with pre-surgical testing, the surgeons, but it's a paradigm shift that we're going to have to gradually introduce, because you need about 3 weeks to treat anemia properly in an iron deficient patient. And iron deficiency is the most common form of anemia. So this is a real paradigm shift, because for those of you who take care of perioperative patients, you probably know that patients don't come in 3 weeks before surgery for their pre-surgical testing. It's more the week of surgery. We also would like to be a liaison to the bloodless community. They have reached out to our hospital and they have told us that they would like to know that we understand their needs and their desires, and that we have a staff on board that are fully capable and educated in caring for these patients. We also have, and let's see, I'm going to bring up these animations and hopefully they'll come up at the right time. And this one is the single unit transfusion campaign. With this, we got from our expert consultant who came from Johns Hopkins. He came to speak to us about 3 or 4 years ago. And what they did was that they put a screensaver on every computer monitor. And when the computer went to sleep, the screensaver said, "Why give 2 when 1 will do?" And it was a single unit transfusion campaign that basically told every clinician that orders 2 units of blood reflexively that you very often don't need 2 units. And in fact, this is part of the clinical decision support that Dr. Chibber was referring to, that when a provider orders 2 units of blood, they will automatically get a message in a stable patient for a stable order. They will get a message that says, often 1 unit is sufficient in a stable, non-bleeding patient. Are you sure you don't want to order 1 first? And this has been successful at North Shore also, and we'll show you some of those data. Moving on to another coagulation improvement technique is thromboelastography. This is a point of care test of coagulation. And it might seem like a complex test, but it's actually very user-friendly and very much decision support based. So I'll show you an image of what the tracings look like, but they're very easy to interpret along with the decision support guidance. And so that is limiting the transfusions of things like platelets and plasma that are measured by this coagulation instrument. And then finally on this slide for blood conservation is limiting phlebotomy. You know, the number one cause of anemia in hospitalized patients is iatrogenic anemia. It is the drawing of blood in large tubes every day, sometimes twice a day. And it is true that many of these blood draws are not necessary. And some of them are duplicate orders. Some of them are multiple providers ordering without realizing someone else has. And we often transfuse we often draw blood in a large test tube, such as these, when smaller ones are available to draw less blood. Now, these little mini bullets are not suitable for some of our laboratory devices in the lab, but these intermediate sized tubes are. And so if there was a suitable tube with the right additives that was a smaller size, that would be preferable. And we're working with the lab to see if we can engage in procuring the smaller tubes. This is the thromboelastogram. This is the device. You put the cartridge in, you put a drop of blood in the cartridge, and a tracing is generated that looks like this. And as I said, it looks a little bit intimidating, but these all indicate either deficiencies of coagulation, which is R, or platelets, which is MA, or fibrinogen, which is alpha, and then fibrinolysis, which is this A30. And you don't even have to interpret these tracings. In fact, you don't even have to see them, but it is helpful to see them because the instrument now gives you the feedback in text, and it says your MA is small. This means you might need platelets, or your platelets are deficient or dysfunctional. So there's a lot of guesswork taken out of using these instruments. And so you can imagine when we do a big liver transplant or a cardiac surgery, and patients have a lot of platelet dysfunction and a lot of anticoagulants on board, that this is very helpful. This tells us if our platelet function is intact, maybe we don't need to transfuse platelets to this bleeding patient. Maybe we transfuse plasma or give a prothrombin complex concentrate, a plasma analog. And this is our repeat normal dashboard. We send this dashboard to all the leaders, the team leaders in all of the different services that order these labs. And we also send an individual report card to each of the highest, I would say, offenders of repeat normal testing. What is repeat normal? Well, it's defined differently for every lab, but in the case of a CBC or a metabolic panel, it would be the daily repeat ordering, it would be repeating the order within 24 hours when the previous result was normal. And that's the whole panel. So these are CBCs that were ordered within 24 hours of a normal CBC. Presumably that shouldn't be necessary if the previous values were normal. And what we see here is the percentage of repeat normal ordering. And you can see this provider had an 8.4%, which probably when they got an email showing that they were out of proportion to their colleagues, they probably did less repeat ordering the next few months. So you can see here a fairly successful intervention, although we are creeping up a little bit. And that's the importance of continued education, is that when we change our practice, that we maintain that improved practice. And so this is something we're working very hard on with the lab. They've helped us generate the dashboard, and with the Department of Medicine, Neurology, Cardiac Surgery, and we have the ordering providers and the attendings of record. So we know who are ordering these repeat normal labs. This is a really tough one. And if anyone here has any suggestions for how to improve this practice, because we have not been able to make as large a dent in this as we have in some of our other initiatives. And this is like Dr. Chibber was talking about how many blood units are transfused by North Shore University Hospital. And when you have such a large N, a fraction of it is still a very large number. So even though this is only a 4% repeat normal rate, when there's 50,000 or 100,000 labs run in a given month, and probably more, 4% is a lot of labs, and it's a lot of lab time, reagents, FTE time, and everything else. Well,
And I think this is
Is-
yours, right?
this
Yeah.
is my slide. This is our choosing wisely. This is our SABM, the Society for the Advancement of Patient Blood Management, and the AABB, the Association of Blood and Blood Therapeutics. They changed their name, Dr. Chiver. I
Yeah,
can't
they
really ever
did.
say it right.
Yeah. Yeah. No,
But
the American Association, like blood and biotherapies.
and
The American Cell Therapy
biotherapies.
too.
Okay. Both of them came up with this, why give two when one will do? So you can see that even different disciplines coming at this problem from different angles, the AABB from a blood transfusion angle and SABM from a blood health angle, still they both came up with why give two when one will do. And this should be our mantra, and it really makes a big difference. So here's an example of some of our clinical decision support and our CPOE. You can see the message here: in stable normovolemic patients, single unit RBC transfusions are often effective and strongly recommended. And that's what comes up when 2 units are ordered. And this is your pride and joy, right, Dr. Chibber? These are the results from the blood bank of single unit transfusion campaign. Now, what you see here are multi-unit orders. These are the percentages of blood orders that were multiple units. And we started looking at this back in 2021 when we introduced the clinical decision support, that message that said, just give one. And you can see that from 20%, we got down to about 15% with some relapsing. And it wasn't until about December of 2021 that the blood bank staff and all of the transfusion safety officers on board began to intervene and notify providers if they were ordering 2 units in a patient that seemed stable and had a non-bleeding indication. So with the communication of the transfusion staff, you can see that the multi-unit orders started dropping and hovering at 10%, 11%. Now we're down to 7%, and our most recent September 2023 was 6%. So I think you're probably a lot more proud of this than I am, but this is great.
No, absolutely. I think the next slide is mine, and I'll just quickly iterate that. Yeah, I mean, going from 20% to 6%. So clearly, these are transfusions that are not happening as frequently as they were before, and basically, this means less patients are getting these transfusions that may not have been helpful, less infections, less possible cancer recurrence. So we're going to end with a quick case. So a little bit about this case we're going to bring up. I know we're getting close to our end of time. So you're assigned to care for a patient. This is a 68-year-old male admitted for elective hip replacement surgery. He has a history of atrial fibrillation, for which the patient takes Eliquis. The patient also takes a diuretic and an ACE inhibitor for hypertension, and the pre-op labs reveal that the patient has normal chemistries, but the hemoglobin is 11, hematocrit 33, platelet count 290. So what are your concerns in regards to patient blood management? And we have a few choices for you, and then I'm going to hand off to Dr. Shorlessison again to discuss them. So, anemia, the atrial fibrillation, being on a blood thinner, the hypertension, and the platelet count. So I'll hand that off back to Dr. Shorlessison to discuss.
Okay, so I think we can see that the first two choices are probably the ones that are most relevant to patient blood management. The others may be of interest, of concern, but not to patient blood management. A platelet count of 290,000 is normal. But the hemoglobin of 11 is low compared by the World Health Organization, which defines 12 in women and 13 in men as normal hemoglobin. So an in-depth workup for the anemia should be sought. Iron studies are usually the simplest. There are other nutritional deficiencies, and what is discovered should, if it's relatively easily treated, should be treated before any invasive procedures are performed on a patient like this. These are the other things that we can do, and we talked about some of them already. If a patient is anemic or susceptible to bleeding and anemia, we can definitely limit blood sampling. We do this in our Jehovah's Witness patients. We limit to the absolute minimum number of blood draws per week that we need to do. And we do draw in the pediatric or the micro bullet tubes for these patients so that we don't phlebotomize and make them anemic. The question we always have is, if you can do it for Jehovah's Witness patients, why can't you do it for everyone? It really is better care, and it's better patient blood management. And then there's the Eliquis, there's the anticoagulant, the DOAC, for the patient's atrial fibrillation. Eliquis is a very, very fine agent. It has been shown in studies to be better than warfarin for preventing clot in patients in atrial fibrillation. And that's why so many of our patients are on these medications. But these patients are at risk for bleeding. So it's very important to understand when the drugs should be stopped before surgery, if they should be stopped, depending on the indication. It also is very dependent on their renal function when the Eliquis is stopped. So in the setting of normal renal function, this drug would be discontinued 2 to 3 days before an invasive surgery or an invasive procedure. If the renal function was abnormal, we would consider stopping for 5 days or even longer, depending on the renal function. So these are the kinds of things that you probably see in your everyday practice as nurses. These are scenarios that we all see, patients we treat, and it may be the nurse that first comes into contact with a patient that's at risk for having an adverse blood event, an anemia that didn't need to be, or a bleeding that caused a patient to need a transfusion. So this patient was treated with iron. Eliquis was held. The patient's now in the operating room. And these are some of the multidisciplinary strategies we have in the operating room. You can see a cell saver machine back here. You see the TEG, which we talked about. This instrument here is a coagulator. It's a form of cautery. And these are things that surgeons will use aggressively in the bloodless population. But why not use it in everyone? Why just use it in the bloodless population? And this actually, excuse me, this is the cautery. This is a thrombin analog that is made of 2 different components that you would spray together and activate the thrombin to help seal a bleeding mucosal surface. So I think this looks like our summary, but certainly we hope you agree with us that as advocates for the patient, the nurse's role is to collaborate with all the healthcare team members and practice patient blood management by minimizing bleeding. This includes the avoidance of unnecessary phlebotomy, administration of medications that enhance coagulation, point of care testing, the avoidance of transfusions unless absolutely necessary. And this contributes to the optimal care of our patients. So I think in the interest of time, we can just tell you that this patient in the PACU had a hemoglobin of 8.4, and Dr. Chibber mentioned the guidelines are posted when you order blood, and this would not qualify as an indication for a stable patient, 8.4. It's greater than, it's 7 or it's 8 in patients with cardiovascular disease. So this transfusion is not indicated. There's the policy. But if the patient was unstable, had cardiac disease, and was having ischemia, that would be a different story. And here are the indications. And 30 minutes later, we have the patient becoming unstable. And there you know that certainly transfusion is one of the options. So why give 2 when 1 will do? And Dr. Chibber, you reviewed this slide earlier, just showing how so many of our transfusions are really not appropriate as judged by experts.
Yeah. And yeah, I think we've made inroads, and we want to continue to do that. And we want to thank you for listening to us and helping support us in our journey and being part of it.
Thank you.
Thank you.